Welcome to this clinical algorithm presentation on the evaluation and management of asymptomatic transaminitis. This step-by-step guide will walk you through a systematic approach to evaluating patients with elevated liver enzymes who have no symptoms. When asymptomatic elevated ALI or AST is detected, step 1 is to confirm the abnormality. Repeat liver function tests if this is an isolated single abnormal value. Take a detailed history and examination covering alcohol intake, medications and herbal supplements, metabolic syndrome, obesity and diabetes, viral hepatitis risk factors, family history of liver disease, and muscle symptoms. Step 2 is to classify severity based on ALT and AST levels relative to the upper limit of normal. Mild elevation is defined as less than 5 times the upper limit of normal. Moderate elevation is 5 to 10 times the upper limit of normal. Severe elevation is greater than 10 times the upper limit of normal. This classification guides subsequent management intensity and workup urgency. Step 3 is the initial laboratory workup, which should be performed in all patients. This includes 4 categories: common and metabolic tests, including CBC with platelets, fasting glucose or HbA1c, lipid profile, albumin, and PTINR, viral testing with HBsAg and anti-HCV, iron overload assessment with serum iron, TIBC, and ferritin, plus a thorough review of all medications and alcohol exposure, including over-the-counter drugs, herbal supplements, and vitamins. Step 4 outlines management based on the degree of elevation. For ALT and AST less than 2 times the upper limit of normal, repeat liver function tests in 2 weeks. If improving or normal, observe with lifestyle modification. If persistent or rising to 2 times or more the upper limit of normal, proceed to comprehensive evaluation in step 5. For ALT and AST greater than or equal to 2 times the upper limit of normal, monitor weekly for 2 weeks, then every 2 weeks until stable or normal, and start comprehensive workup immediately. Step 5 involves second-line evaluation when common causes have been excluded. This includes 3 categories: autoimmune testing with ANA, SM, anti-LKM1, and serum IgG. Metabolic and genetic testing, including alpha-1, antitrypsin level, and phenotype. Ceruloplasmin, especially in patients under age 40. And TSH. Other tests include tissue transglutaminase antibody and creatine kinase if AS predominates. Step 6 is imaging. Abdominal ultrasound is the first-line imaging modality used to assess steatosis, which supports MASLD diagnosis. Cirrhosis features biliary obstruction and focal liver lesions. Step 7 addresses when MASLD is suspected. Calculate fibrosis risk using the FIB4 index and NAFLD fibrosis score. For low-risk patients, recommend lifestyle modification and monitoring. For intermediate or high-risk patients, refer to hepatology and consider liver biopsy. Step 8 covers red flags and urgent actions. Stop potentially hepatotoxic drugs if ALT and AST are 5 times or more the upper limit of normal, or if bilirubin is elevated. Refer to hepatology if there is persistent elevation for more than 6 months, ALT and AST 5 times or more the upper limit of normal, low albumin or elevated INR, high fibrosis scores, or unclear diagnosis. Consider liver biopsy if there is persistent unexplained elevation for more than 6 months, suspected autoimmune hepatitis, high fibrosis risk, or steroid refractory hepatitis. Universal management applies to all patients. This includes alcohol cessation or strict moderation, weight loss with a target of 7 to 10% body weight, avoiding hepatotoxic drugs and supplements, management of metabolic syndrome components, and controlling diabetes, dyslipidemia, and hypertension. For reevaluation timing, if ALT and AST are less than 2 times the upper limit of normal, repeat in 2 weeks. If 2 to 5 times the upper limit of normal, Monitor weekly for 2 weeks, then every 2 weeks. After a lifestyle modification trial, reassess at 3 to 6 months. For persistent elevation, consider hepatology referral at 6 months. Key points and common pitfalls to avoid. Do not assume drug-induced liver injury without excluding viral hepatitis, as hepatitis E can mimic drug-induced injury and requires specific testing. Do not ignore isolated AST elevation. Check creatine kinase to exclude muscle disorders. Do not delay workup in patients with risk factors for advanced disease, as older age, diabetes, obesity, and prolonged elevation warrant aggressive evaluation. Do not forget extrahepatic causes such as thyroid disorders, celiac disease, and hemolysis. Do not overlook medication and supplement history, including over-the-counter drugs, herbal supplements, and vitamins. The key point is to systematically exclude common causes first, including MASLD, alcohol, viral hepatitis, medications, and hemochromatosis, before pursuing rare diagnoses, while maintaining appropriate monitor intervals based on severity.